This lecture covers the diagnosis of the calcium and the phosphate-related disorders. The calcium is a very widely distributed ions. In our body, we do have about 1.1 kilogram in a skeleton, mainly in the skeleton. Another part that we have mostly in the plasma, in the extracellular fluid. The calcium is needed in the nervous system, in the muscle, for the muscle contraction, for the clotting mechanism, and then exocytosis. The phosphate is a component of the DNA, RNA, or the ATP and the phospholipid and serves as the pH buffers. In our body, we have about 700 or 800 gram in an adult skeleton, and the plasma concentration is ranging from 0.8 to 1.5 millimole per liter. There are two forms of the phosphate. There's a biphosphate and a monophosphate form that we do have. Now the ion balance, if we do have changes in the phosphate level, that doesn't have too much effect on the body. However, if we do have an altered calcium concentration, that can be serious in our case. For example, the hypocalcemia, when we do have a lower calcium level in the blood, in extracellular milieu, that causes excitability, increased excitability of the nervous system, and muscle spasm, tremors, or tetany can develop, usually when the concentration drops around 1.5 millimole per liter. Laryngospasm and suffocation can develop if the concentration drops around 1 or below 1 millimole per liter. In the opposite of the hypercalcemia, when the concentration is higher in the serum, relatively muscle weakness and sluggish reflex and cardiac arrest can happen. Usually this gives you about 3 millimole per liter, above 3 millimole per liter. Now, what's going to do this effect? If we do have a hypocalcemia, and when we do have less bivalent cations that surrounding the sodium channels, this way the sodium channels can be opened more easily. So this way the sodium enters the cells, and these fast opening sodium channels can induce changes of the membrane potential, so they can reach the threshold. This is why the excitability increases. In the opposite, when we do have more bivalent cation, that's making, let's say, the blunted effect of the sodium, so the sodium channels less likely to open. So this is why it's going to depress the nervous system. In the picture, you can see this carpopedal spasm that usually develops when we do have a hypocalcemia. That can be the first sign of a hypocalcemia. Now, calcium and albumin. The calcium is present in the plasma in 3 different forms. Mostly of the calcium is bound to a protein, or about the same value is bound to the protein, and the same amount is in the free form or the ionized form. Physiologically, the ionized form is very important, so that's an effective form, and we do have an additional about 10% that complex with ion, citrate, sulfate, and phosphate. So because the ionized free calcium is important and the concentration is ranging from 1.1 to 1.4 millimole per liter, and this is very strongly depending on the amount of protein that we do have in a plasma, that mainly albumin. And in certain diseases such as a nephrotic syndrome or liver diseases, when the albumin level decreases, this calcium, the total calcium level, doesn't reflect whether the patient has a hypo or hypercalcemia. This is why when we measure in the routine lab, the total calcium is measured, we cannot directly state what the free calcium level is. This is why we should use, let's see, or we could measure the ionized calcium using an ion selective electrode. Nowadays, relatively is easy to measure, and you can ask the measurement for the ionized calcium, but the lab generally measures the total calcium. Now, another very important thing is that the pH will alter the calcium, the bound calcium very muchly, because if the pH increases, that will decrease the ionized calcium, because the changes of the protein, the albumin charges, more calcium will bind to the albumin. So, and this is what we meaning is, if the pH increases or changes about 0.1, that can go and that can change the ionized calcium level about 0.05 millimole per liter. Now, what can we do with this albumin level? In a case when we do have a low albumin level, we can correct we can determine what could be the calcium concentration if we normalize with the albumin level. If we do have a hypoalbuminemia, the corrected calcium level is always higher than the actually measured serum total calcium. That's the formula that they are using. The corrected calcium level should be the measured calcium plus you give 0.2 times the difference between the normal albumin concentration in gram per liter, such as a 40, and the measured albumin concentration. The serum albumin should be measured in a case if the ionized calcium is not available in our case. Now, what's going to regulate the calcium and phosphor homeostasis? There are at least 3 different hormones. I'm not mentioning the calcitonin here, but the calcitonin has an other effect that I will mention right now. So what is the essential for this regulation to maintain the normal calcium and phosphate level? The major, let's say, hormone or endocrine gland, the parathyroid gland, that releases parathyroid hormone or calcitonin. These are the 2 hormones that release from the thyroid gland. Essentially, the parathyroid hormone, the PTH, is going to increase the calcium level in the serum. That will promote the absorption of the calcium from the bone, or potentiate the reabsorption of the calcium from the kidney. So it's going to decrease the excreted calcium, while at the same time it will increase the excretion of the phosphate through the kidney. So the net be the increase of the ionized calcium. Now, what other role of the PTH has? PTH, it will activate the 1-hydroxylase enzyme, so it will make more active vitamin D, 1,25-dihydroxycholecalciferol. Now, the effect of the cholecalciferol to act and induce the absorption of the calcium and phosphate from the intestine. Now, another thing, when we do have an increased PTH will induce or will promote the secretion of the fibroblast growth factor 23, that's basically made by the bone, and this FGF23 is going to stimulate the excretion of phosphate. So basically, FGF23 stimulates the phosphate excretion. However, meanwhile, when we do have, for example, an effect of the FGF23, that will inhibit the active vitamin D formation. And an additional effect of the FGF23 that will inhibit of the PTH release. So we do have at least 2 feedback loop for the FGF. We have the PTH, and we do have the effect of the vitamin D as well. And the vitamin D has a direct effect to regulate or inhibit the PTH release. However, as you see here, the vitamin D is essential, for example, for the effect of the PTH to induce the reabsorption of the calcium, so through the rank ligand. We do have different receptors of the PTH, for example, the PTH1 receptors on the bone that will act and activate the osteoclast and the bone resorption. And we do have another type of the PTH receptor, the same one receptor on the kidney that regulate the tubular reabsorption of the calcium and is going to alter the sodium phosphate co-transport mechanism. Very similar, we do have this this receptor activated nuclear factor, that's a rank in the bone that activates the osteoclast, but we do have some different calcium sensing channels or calcium receptors, such as the TPRV or M. They are both sensing, very sensitive to the calcium, and this is how the effect is working on. Now, when we do have an elevation of the calcium, it will relatively sensed by the calcium sensor receptors on the thyroid gland and secrete calcitonin, and calcitonin is going to inhibit the PTH release. This is how and what is going to happen and how this calcium and phosphate homeostasis is maintained. Now let's look at these different hormones. Calcitriol, this is the activated vitamin D. This is produced by the following process. UV radiation of the epidermal cells, keratocytes, convert the steroid derivative of the cholecalciferol to D3. And liver converts it to the calcidiol by having this 25-hydroxylase activity, while kidney converts it to the calcitriol, that's the most active vitamin D. Now, calcitriol behaves as a hormone that raises blood calcium, as I mentioned before, increases the intestine absorption of the calcium and phosphate. This is going to happen to the cal-binding protein, or an additional one in the bone usually is done with the osteopontin, or increases the cells differentiating into the osteoclast. This is why the synergistic effect of the PTH, or stimulate the PTH effect, or promote urinary reabsorption of the calcium ion. Now, decreases the calcitriol, decreases the PTH production and the release. This is a feedback mechanism, and regulates a lot of gene expression to the VDR, the vitamin D receptor, that's a nuclear receptor. Now, if we do not have enough vitamin D, mostly that is happening, for example, that the bone is going to be softened. That's causing rickets in children and osteomalacia in adults when they don't have any vitamin D. Now, this is the summary of the calcitriol synthesis. So, as we mentioned in the skin, that's a 7-dehydrocholesterol is converted to vitamin D3, and this is it's hydroxylized in the liver, and in the kidney is going to make the most active vitamin. This is a calcitriol. That's the endocrine homeostasis. However, some other organs, we can have a prostate, breast, colons, and other beta cells, again, that can produce this active hormone, and they do have a little bit different effect, because as an autocrine paracrine action, the cell proliferation can be decreased or differentiation increases, and they do have a very important immunoregulatory effect on it. Now, calcitonin is secreted by the C cells of the thyroid gland when calcium concentration rises and is too high and inhibits the PTH is released. The function. What is the function? Basically, the function is reduce the osteoclast activity as much as 70%, especially during childhood, where the increased number and activity of the osteoblast as well. It's very important in children, and in adults they do not have too much effect. Relatively, the osteoclasts are more active in children, and any kind of deficiency that could occur in elderly doesn't have any kind of significance, importance. There is no disease caused by the hypocalcitonemia, and reduce bone loss and in osteoporosis relatively. Now, the fibroblast growth factor 23, or FGF23, that produced by osteocytes in the bone. FGF23 expression is stimulated by, as we said previously, by hyperphosphatemia and calcitriol, so vitamin D, and elevated phosphate level. The phosphate-related effects that on the kidney, for example, suppress the tumoral sodium and phosphate transporter mechanism and causes phosphaturia, and inhibits 1-hydroxylase activity, so the active vitamin D level it increases, plus it will induces 24-hydroxylase activity that again inhibiting or decreases the active vitamin D formation and indirectly decreases the intestine phosphate absorption. Other effects can be the parathyroid gland that inhibits directly the PTH secretion, and the heart that directly induces cardiac hypertrophy if the level is too high. Parathyroid gland. The parathyroid gland located on the posterior surface of the thyroid gland, and the release, the PTH release, is regulated by the ionized serum ionized calcium level. The major function of the PTH to rise calcium in the blood. It's usually happening when the PTH activate the rank ligand and increase the osteoclast population and promote the calcium resorption as well. Plus, it will affect on the kidney, will promote the phosphate excretion and promote the calcium reabsorption. And at the same time is promote the calcium-triosynthesis in the kidney by activating 1-hydroxylase enzyme. Another effect of it inhibits the collagen synthesis and bone deposition by the osteoblast. Now, sporadic injection, however, of low levels of the PTH could cause bone deposition. It can induce the formation of the bone-forming unit of the osteoblast osteoclast.
Osteoclasts are the specialized cells that resorb bone, and osteoblasts are the cells that form new bone. The discovery of the rank ligand pathway has been an important advance in our understanding of bone remodeling. Rank ligand, a protein expressed by osteoblasts, plays a key role in osteoclast formation, function, and survival through interaction with its receptor rank that is expressed on the surface of osteoclasts. Osteoprotegerin, or OPG, another protein secreted by osteoblasts, is a natural inhibitor of rank ligand and plays a role in regulating bone resorption. At the initiation of bone remodeling, lining cells move apart to expose the bone surface, become osteoblasts, and begin expressing rank ligand. Rank ligand binds to rank on osteoclast precursors, which initiates cell fusion and the formation of mature multinucleated osteoclasts. Rank ligand continues to bind to rank on mature osteoclasts. The binding of rank ligand to rank is essential for osteoclast formation, function, and survival. Following bone resorption, osteoblasts migrate into the pit. Osteoblasts fill the pit with new bone matrix. Some osteoblasts become embedded within the matrix and eventually turn into osteocytes, while others become new lining cells on the bone surface. In the final stage of remodeling, newly created bone matrix mineralizes and the bone returns to a resting state.
So this is how the rank ligand or drives an increase in osteoclast activity. The very important one, the ratio of the rank ligand and osteoprogenin. When we do have a high ratio, that meaning that will promote the osteoclast activation and bone resorption. And when this ratio is low, now we do have a bone or formation, so it's going to inhibit the osteoclast activation. Now, overview the calcium balance in our body relatively what is going to determine the calcium level in the blood. Basically, we do have an input from the outside world. This is the GI absorption of the calcium, and we do have another excretion that is going to the outside of the world. That's mainly happening in the urinary excretion of the calcium. Now, we do have an equilibrium in the bone, that we do have a mineralization or the bone formation, and we do have a resorption from the bone. So this is going to maintain the normal steady state calcium level in the blood. If we do have hypercalcemia, the reason can be if we do have an increased GI absorption or increased bone resorption or decreased bone mineralization or decreased urinary excretion. Hypocalcemia in the opposite can happen when we do have a less absorption from the intestine or decreased bone resorption or increased bone mineralization or increased urinary excretion. So this is the major pathophysiology of the calcium homeostasis. Now, the etiology of the hypocalcemia, as we mentioned before, that could be due to the decreased GI absorption. For example, if we do have a poor dietary calcium content of our food, or impaired absorption, for example, that's related to the calcium, for example, vitamin D deficiency. If we do not have enough dietary intake of vitamin D, or we do have a malabsorption syndrome, or if we do have an internal problem, we do have a decreased conversion of vitamin D to the more active form of this called Calcitriol. For example, that's happening in liver failure, chronic kidney diseases, or low PTH level, or hyperphosphatemia. Another thing, when we do have a decreased bone resorption and increased mineralization, so bone formation, that can be due to, for example, the pseudo-hypoparathyroidism, when we do have a receptor problem with the PTH, or we do have a vitamin D deficiency when we do have a low calcitriol level. Or another thing, that's a hungry bone syndrome, especially this is happening when somebody had a long-term hyperphosphatemia and an elevated PTH effect, elevated bone resorption, usually is happening at chronic kidney diseases. And after, for example, kidney transplantation, everything goes back to the normal. However, the lost calcium that the bone is released is going to be restored in the bone, and that's decrease the calcium level because we do have a net influx toward the bone formation. Or when we do have, for example, an increased osteoblastic activity, for example, osteoblastic metastasis. Increased urinary excretion, when we do have a very low PTH. The symptoms can develop, for example, after thyroidectomy, or if somebody was treated with a radioactive iodine, or autoimmune hypoparathyroidism can develop, or PTH resistant cases, for example, in vitamin D deficiency in a low calcitriol level. Extracellular calcium deposition can happen if somebody has a hyperphosphatemia due to, for example, tumor lysis or chronic kidney diseases. Now, the hypercalcemia, the etiology, can be very similarly to the increased GI absorption when we do have an elevated calcitriol level, vitamin D excess dietary intake, or granulomatosis diseases, because these granulomas can have 1-hydroxylase activity, or elevated PTH release, or hypophosphatemia, or increased loss of the bone. For example, increased net bone resorption when we do have an elevated PTH. That can be primary, secondary, or tertiary hyperparathyroidism. On long-term immobilization, because the amount of bone usually is depending on the physical activity of the stretch of the bone. Malignancy, osteolytic metastasis, or PTH-related peptides secreting tumor can cause this one. Increased bone turnover in some diseases, such as, for example, Paget diseases or hyperthyroidism, can increase the calcium level. Decreased bone mineralization can happen if somebody has, for example, an elevated PTH or aluminum toxicity. Or decreased urinary excretion, for example, some diuretics, thiazide diuretics, or elevated calcitriol level or elevated PTH level can lead to this problem. Hypercalcurias can happen when we do have an increased calcium excretion in the urine. The best way to measure the calcium excretion if we measure the urinary calcium together with the creatinine concentration, and because this ratio is mostly stable and the normal value is 0.1 to 0.7. Alone the calcium doesn't tell you too much. The secondary hypercalcurias usually is due to some other diseases. Usually that's be the consequence of hypercalcemia, such as, for example, the primary hyperparathyroidism or malignancy or anything else that will cause an increase of the calcium and increase in the serum. And another thing can happen when we do have a tubular calcium loss. That's a very rare situation. Ideopathic hypercasurias, we have no clue what the cause is. Probably some kind of transporter mechanism is genetically altered. But the most common cause, this be the most common cause of recurrent nephrolithiasis, for example, 50% of the cases. In this case, the PTH level usually is low or normal, and the body mass density is lower one, but the osteoclast activity is higher one. The possible cause can be some kind of infection or immune-mediated processes or inflammatory processes when interleukin-1 tumor necrosis factor alpha and the granule monocytes colony-stimulating factor overexpression happening in the leukocytes of some patient. And some patient relatively has an increased intestine sensitivity to the vitamin D. Hypophosphatemia, the hypophosphatemia could be due to, for example, the chronic alcoholism or urinary phosphate wasting, such as a Fanconi syndrome, a part of Fanconi syndrome, or tumor-induced osteomalacia or chronic ingestion of antacids that again can cause hypophosphatemia. Symptoms, mild and acute hypophosphatemia is asymptomatic, there is no sign. The clinical symptoms when the serum phosphate level is decreased below 0.32 millimole per liter, relatively that's inhibited distal tubular reabsorption of the calcium with an unknown mechanism that leads to hypercalcemia immediately. Or increased bone resorption includes calcitriol synthesis leads to osteomalacia. And the manifestation of intracellular phosphate depletion that lead to a decreased ATP amount of synthesis, that the myocardial function decreases, the pulmonary function, the diaphragm ability decreases, proximal myopathy can develop, dysphagia, and ileus can develop when somebody has a very severe hypophosphatemia. Hyperphosphatemia, when the phosphate concentration basically it's determined mainly by the kidney excretion, and usually this is a kidney disease is associated with hyperphosphatemia. However, the causes can be cell lysis, mostly the tumor lysis syndrome when it's induced by chemotherapy of lymphomas, for example. But rhabdomyolysis, and when we do have a muscle cell destruction, that's a myoglobin-induced acute kidney injury, increases severity of the hyperphosphatemia. Or intestine uptake or vitamin D toxicity can cause a hyperphosphatemia. Cellular shift in the lactate acidosis or ketoacidosis, again it can cause hyperphosphatemia. Or decreased renal clearance, the GFR decreases that is happening in acute kidney injury or chronic kidney diseases. Or increased tubular reabsorption, if, for example, in hypoparathyroidism or pseudohypoparathyroidism, in acromegaly, or biphosphonate stimulated phosphate reabsorption, or vitamin D toxicity, again, it can cause. The symptoms usually secondary calcium disorders and due to the increased PTH level or the increased the FGF23 levels. Now, let's look at the mechanism of the secondary hyperparathyroidism in chronic kidney diseases, because this is the most common cause of the secondary hyperparathyroidism. In chronic kidney diseases, when the nephron number is decreased, the effect, the mass of the tissues that will cause a decrease of the 1-hydroxylase activity, and it will cause a decrease of the urinary phosphate excretion, and it will stimulate the elevated phosphate level is going to stimulate the FGF23. The FGF23 is further, it will decrease the 1-hydroxylase enzyme. This is why we do have less active vitamin D formation. That can lead to hypercalcemia and in the same way hyperparathyroidism. Now, what will happen, the urinary phosphate level, when it increases, we do have a hyperphosphatemia. Hyperphosphatemia directly can inhibit the 1-hydroxylase enzyme activity, plus it will reduce the calcium level, causes the hypocalcemia, and directly can stimulate the parathyroid hormone releases. This is why we do have an elevation of the PTH level in a case of the chronic kidney diseases. Now, chronic kidney diseases and phosphate. When we do have a high serum phosphate level, even with a normal kidney function, that's where increase the risk of the left ventricular hypertrophy and cardiac insufficiency. The renal patient have elevated serum phosphate level, that's increase the risk for the ectopic tissue calcification in the vessels or tissues everywhere. Serum phosphate strongly correlates with the mortality in the dialyzed patient. In chronic kidney diseases, as I mentioned before, elevated the serum PTH and FG23 level and have higher risk for cardiovascular mortality. Hyperphosphatemia induces PTH and FGF23 secretion and inhibits 25-hydroxy-D vitamin formation, and in the kidney it inhibits the 1-hydroxylase enzyme activities. This is why we do have less active calcitriol. The elevated PTH and FGF23 causes bone resorption and cardiac hypertrophy. Our goal is to avoid hyperphosphatemia and decrease the PTH and the FGF23 level in the chronic disease patient. Now, vitamin D deficiency, the symptoms is relatively mild or asymptomatic, and the patient could have an elevated PTH level in about 40% of the cases, but they do have an increased risk for the accelerated bone loss and fractures. The severe deficiency leads to hypocalcemia and secondary hyperparathyroidism. In adults, the phosphaturia, bone demineralization, and osteomalacia can develop. In children, rickets and osteomalacia will develop. By the same time, muscle weakness, bone pain, and tenderness and fracture could happen. There are some important roles of vitamin D independent of the calcium and phosphate metabolism. It mainly works through the vitamin D receptor, the nuclear receptor, that's going to alter the function of the monocytes macrophages. That is going to alter the cytokine and immunoglobulin release. So they do have an immunomodulatory effect. But vitamin D also affecting and maintain the normal cell proliferation. So this is the anti-carcinogenic, for example, that has been shown in breast, colon, and prostatic cancer. Also, it's important to regulate the insulin sensitivity of the, for example, in the pancreas, so it can prevent the development of the autoimmune diseases such as the diabetes mellitus as well, type 1 or type 2 as well. But it's affecting all the parathyroid gland as well, and is going to regulate the vitamin D synthesis and the blood pressure and the renin release as well. So they do have much more effect than only on the calcium and the phosphate metabolism. Now let's talk about osteoporosis. Osteoporosis is characterized as a metabolic bone disorders when the bone mass is going to decrease, and not only the mass decreases, but the microarchitecture architecture of the bone is altered and deteriorate the bone function, and that will lead to the increased bone fragility and the patient be more susceptible to the fracture. Now, if you look at these two graphs, you can see that on the right side, we do have an osteoporotic bone when we do have a loss of trabecular plates, and that's resulted in the weakening of the bones, and compared to the left one when we do have a normal bone structure. And of course, if we do have a weakened bone, that will increase the risk to develop any kind of fracture. Now, what will be the risk for the osteoporotic fracture? Basically, if somebody had a history with a fracture as an adult, or history of a fracture in the first degree relatives in the family, and a caution, for example, rest, or female, if they do have a low body weight, estrogen deficiency, especially in the early menopause, if it's happening before the age of 45, or bilateral oophorectomy, or prolonged amenorrhea for more than 1 year. Now, another risk factor for osteoporotic fracture can be the hypogonadism in men, alcoholism, cigarette smoking, low calcium intake, lifelong, inadequate physical activity, that's very, very important, dementia, recurrent falls, or poor health and frailty. Now, let's see the classification of the osteoporosis. There are two major categories, primary and secondary. Primary, that itself some kind of alteration of the bone remodeling is happening, and that leads to the decrease of the bone mass, and that can be the postmenopausal osteoporosis, or it can be the age-related or the senile type of osteoporosis. Now let's look at first the postmenopausal osteoporosis. If we do have a decrease estrogen that results in an increased osteoclastic activation, and with that increases the osteoblastic activation. That meaning the bone loss be about 2 to 3% a year of the total bone mass, and that will cause a very rapid bone loss. So the most common fracture site, usually the vertebrae and the distal forearm. The age-related or senile osteoporosis that usually starting after the third decade, and life starts slowly decline in the bone mass, but this never exceeds about 1% per year. So that meaning the postmenopausal is about 2 times is higher. Now, most common types of fracture in the hip and the radius, and more commonly that occurs in female and male. In both cases, now in a postmenopausal one, what could be the problem why the female is more affected than a male? Because the bone mass by the age of 30 is much higher in a male than a female one. And the testosterone is important to build up more bone, and usually if the physical activity is higher one, that can keep the bone mass. However, it declines very slowly in male as well, but in the lifespan that we live, relatively the fracture, the pathologic fracture doesn't occur too much, and this is why it's a problem. If a postmenopausal osteoporosis occurs in male, that could occur, and also this is correlated with the estrogen. We do have an estrogen, but of course it's lower grade and lower level that we do have, but it still can regulate this estrogen or osteoclastic activity. The secondary osteoporosis usually that is induced by different diseases. Now, let's compare the characterization and the evolution of osteoporosis and the senile type of the osteoporosis, or the postmenopausal or the senile type. The type 1, that is meaning that's the postmenopausal one, and type 2, that's the senile form osteoporosis. Usually, if you look in the age, the type 1, the postmenopausal, occurring right after the menopause, and by the type 2, it's occurring mostly over 70. The sex ratio, it's much higher in postmenopausal, is 6 to 1, compared to the senile one is 2 to 1. The type of bone that is affected, usually in postmenopausal, the trabecular bone, while in the senile one, both trabecular and the cortical bones are affected. The rate of the bone loss is accelerated, as I mentioned before, about 2 to 4 times is higher than is a normal situation. That's about 1% is lost per year. The fracture size, this was different from, because usually the vertebrae, usually the crush is happening, and the distal radius. Why in the senile one, vertebrae and the hip or the vertebrae is most important one. PTH level is decreased in the postmenopausal, Y is increased in a senile one. calcium absorption decrease in both cases. Why? Let's see, the conversion or the active vitamin D formation is secondary decreases in case of the postmenopausal porosis. Why? In primary problem in the involutionary osteoporosis, because the sensitivity of the cells is decreased by age.
After the age of 30, bone resorption will slightly exceed formation and bone mass begins to diminish. In women, this can become even more of an issue following the onset of the menopause, where declining estrogen levels further increase the rate of bone resorption. Osteoclasts are regulated by various signaling molecules, including rank ligand. Rank ligand promotes the differentiation, activation, and survival of osteoclasts via an interaction with its receptor, rank. Once activated, osteoclasts resorb bone. However, the hormone estrogen is thought to repress rank ligand signaling. Downregulation of rank ligand expression leads to decreased activation of rank and a subsequent decrease in osteoclast-mediated bone resorption. Estrogen has also been shown to stimulate the expression of osteoprotegerin, which inhibits the activity of rank ligand by preventing it from interacting with its receptor. Following the onset of menopause, estrogen levels start to decline. This can lead to increased rank ligand production, which is associated with increased bone resorption in postmenopausal women. Increased bone resorption after the menopause leads to the accelerated loss of bone mineral density, which can result in the more severe condition of postmenopausal osteoporosis, in which the skeleton becomes increasingly susceptible to fracture. Vertebral collapse is often secondary to osteoporosis and is more prevalent in women. In osteoporosis, the thickness of both cortical and trabecular bone decreases over time, suggesting that both of these structures play a role in the development of vertebral fractures. These events, such as fragility fractures of the hip or vertebrae, may contribute to the painful and debilitating symptoms that can arise from osteoporosis. Several other factors influence the rate of bone mineral loss. These include genetic factors, lifestyle factors, and the use of certain medical therapies, all of which are thought to play a role in the development of osteoporosis.
The secondary osteoporosis, there are some diseases that is associated with the loss of the bone mass, such as, for example, happening in acromegaly, or Addison disease, amyloidosis, or anorexia, or chronic obstructive lung diseases, pheochromocytosis, hyperparathyroidism, lymphomas, and so on, and so on. So there are a lot of diseases that could be cause osteoporosis, secondary osteoporosis. Now, there are some drugs also that can lead to the decrease of the mass, such as the aluminum-containing drugs or anticonvulsants or excessive alcohol ingestion or hyperthyroidism or basically Depo-Provera that decrease bone mass reversibility after stopping the medication. Glucocorticoids that are huge drugs that is used very much, or heparin, lithium, etc. Now, osteoporosis in metabolic syndrome, that's very, very important that the metabolic syndrome is associated with the low-grade inflammatory processes. And when we measure, for example, the high sensitivity CRP test, that we can see that CRP is elevated. It's still in a normal range. However, it's not exceeding, for example, 10, but it can be higher than a normal, that up to, for example, 3 milligram per liter. The metabolic syndrome patient shows an excess bone resorption and impaired bone formation. And elderly men with an increased CRP level values have independent risk for vertebral fracture, that independent from the body mass density, and also has a higher chance to develop a atherosclerosis. Now, how do we measure the bone mass? This is what we're using, the bone mineral density. This is what they are checking it using a dual energy X-ray absorptiometry, the DEXA scan. The results usually is expressed at the T-score or the Z-score. The difference between the T-score and the Z-score is usually what the bone mass that we are comparing the actual one. The T-score is going to compare the bone density to the maximum bone density of that are reached at the age of 30 in an adult in the same gender and an ethnicity. But the Z-score is always considering the same age and gender and ethnicity. The more sensitive is the T-score. This is why usually the WAG criteria for osteoporosis expressed in the T-score. The normal T-score, that the mean of the BME plus the standard deviation. Now, if the BME is out of the standard variation plus minus 1, this is not going to cause any problem. However, if the T-score is out of the 1 or 2.5 less than the normal, let's see, bone density, that's mean osteopenia, and we call osteoporosis if the T-score, so the standard deviation is out of the 2.5 less than the normal body mass density. Now, what is the indication for the bone mass density testing? Usually the women over 65 and men over 70 should be checked regardless of the clinical risk factor. And in postmenopausal women, younger women, usually and menopausal transition, and age and the man age of 50 to 70 with critical risk factor for fracture, adults who have a fracture after the age of 50, and adults with a condition associated with low body mass, for example, rheumatoid arthritis, multiple myeloma, or Cushing syndrome, for example, or taking some medication that can accelerate the bone loss, for example, glucocorticoids. Now, what can be the laboratory markers of the osteoporosis? First of all, when we do see that the body mass is decreased, we can use the markers of the bone metabolism. Now, if we choose the right markers, we can see which is the altered part, whether the bone formation or a bone resorption is accelerated. Okay. So this is why the diagnostic only with the body mass density is important. So together we have to make this decision. Let's see some markers that is used and that can reflect the bone resorption. This is what is called Osteoclast activity. Osteoclast activity can be measured by measuring the serum collagen 1 N-terminal telepeptide, NTX, and the C-terminal telepeptide. But there are some other ones, serum tartrate resistance acid phosphatase, for example, or urinary hydroxyproline and hydroxylysine content. The bone formation markers, such as measuring the osteoblast activity, that can be the osteocalcin, that is important, and procollagen 1 C-terminal propeptide or N-terminal propeptide. So whichever is emphasized in red, those are the most important that can be checked today.